So good evening to our New Zealand guests and good morning also to friends in Europe. Welcome. Tēnā koutou katoa, ngā mihi nui kia koutou katoa, ka ranga mai mihi mai. Ko au, ko ka pukatau mā haka te maunga, ko Owhio te awa, no Otipoti ahau, ko te whanganui a tāra te kāinga, ko Kāli Mercy a toka ingoa. Hello from Taputeranga in Wellington. Welcome to everyone joining us today, this evening or this morning. I'd like to start this webinar off in the right way with a karakia or a reflection in te reo Māori. Tuia ki runga, tuia ki raro, tuia ki roto, tuia ki waho, tuia te here tangata, ka rongo te pō, ka rongo te ao, tuturu whakamaua kia tina, tina, haumi e, hui e, taiki e. So that karakia calls on us to unite and come together as one, which we're doing today to talk about how we can help to minimise harms from methamphetamine use in both New Zealand and Norway. It's an incredibly important topic, and I just want to acknowledge that many people in the audience have experienced issues themselves with methamphetamine use or have suffered under the criminal justice system or the criminal justice response that we currently have for methamphetamine and other drugs, or have loved ones who have done so. So this webinar is for you and also for all of us to explore together how we can do better. My name's Kāli Mercy, as I said before, and I'm Acting Director at Aotearoa, which is the Helen Clark Foundation. The foundation is a public policy think tank based at the Auckland University of Technology and founded on the values of our patron, former Prime Minister of New Zealand, Helen Clark, who is, of course, joining us today. Welcome, Helen. We're delighted to be running this webinar in partnership with the Centre for Sustainable Healthcare Education in Norway, also with the University of Oslo, the Arctic University of Norway, and the New Zealand Drug Foundation. So I'm shortly going to hand over to others to lead the webinar, but I just wanted to give some quick housekeeping matters first. So your microphones are all muted, so we can't hear you. Hopefully you can hear us. If you have a question, we'll be taking questions at the end of the session, and you can use the Q&A session down the bottom of your screen to ask those questions. You can also vote on other people's questions to raise them up the priority list so we're more likely to answer them. If you can also use the chat function, but we may not see questions in there, so please do put your questions into the Q&A function button. We're also going to be recording the webinar, and you'll be able to watch it afterwards again on the Helen Clark website or on our YouTube channel. So just quickly, the structure of our talk today. I'm going to hand over shortly for a quick hello from Ivan, who's welcoming us on behalf of the University of Oslo. And then Emma Lingley, also from the University of Oslo, will then run the webinar for us. Philip is going to start with a short presentation summarising the key findings from our report, Minimising the Harms of Methamphetamine, this one. Sorry, a bit blurry. If you haven't looked at it yet, I really do recommend that you take a look. It's got a huge wealth of information in it. I'll put the link up in a minute. So Emma's then going to ask our panelists each a few questions. We expect that will take about an hour, and then at the end we should have 15 good minutes for questions from the audience, from you guys. So that's enough for me, more than enough probably. I'd just like to thank all our panelists very much for being here for what promises to be a really interesting session. Without further ado, I'll hand over to you, Ivan, to introduce yourself.
Kia ora and warm greetings to everyone on behalf of the Norwegian team. So my name is Eivind Engebretsen, and I'm a professor in interdisciplinary health science and the head of the Center for Sustainable Healthcare Education at the University of Oslo. And at our center, we are passionate about advancing sustainable health and heightening awareness of the Sustainable Development Goals among healthcare professionals. But we believe that we can only accomplish this by fostering a transformative and a critical approach to medical education. And our aim is to empower health workers with not only the necessary skills for doing healthcare tasks, but also with the capacity to challenge the systems in which these tasks are performed. And as Audre Lorde famously observed, the master's tools will never dismantle the master's house. So to effect sustainable change, we must confront the very systems and hierarchies and social structures that created the problems we seek to resolve. Drawing on the valuable insights of the Helen Clark Foundation's report, this webinar emphasizes the need for both Norway and New Zealand to address the underlying social and political determinants of addiction. The detrimental consequences of substance abuse in general and methamphetamine use specifically underscore the importance of a holistic approach to social and health issues, as well as a critical perspective on the institutions in which these issues are addressed. And by recognizing the interconnectedness of social, economic, and cultural factors driving addiction, we can move beyond simply criminalizing drug use and shift towards a more inclusive and comprehensive strategy that the report underlines. So before we begin, I would like also to express my gratitude to the Helen Clark Foundation and its patron, Helen Clark, for hosting this event. And we are also very grateful to our distinguished panel of experts for taking the time and sharing their insights and expertise with us. And then I will hand over to my colleague, Emma Lengle, who is a medical doctor and a PhD student in community medicine at University of Oslo and affiliated to our center.
Thank you, Ivan. Welcome, everyone. I will try and lead us through this webinar and be interacting with panelists to discuss the report and the impact of methamphetamine addiction in Norway and New Zealand. To kick us off, we will have introductions from our panelists. So Helen, if you could please start.
Hi, I'm Helen Clark, and for the purposes of this webinar, I'm the patron of the Helen Clark Foundation and also the chair of the Global Commission on Drug Policy, which advocates against prohibition and for decriminalisation and the regulation of the use of drugs. We feel that prohibition's been utterly counterproductive and very costly in terms of human life, abuse of human rights, and many other issues. So that's the background I come to this with tonight. I now hand over to Philippa, who was the author of the Helen Clark Foundation report. Philippa.
Good morning and kia ora to our panel guests. I am the lead author of the report. I'm an economist by training and have background in public policy. In my spare time, I do a bit of public health advocacy on firearms, and I also did this as a pro bono project. And I'd like to hand over to Tricia. You're on mute, Tricia.
Kia ora tātou, ko Tricia Walsh ahau, no te tai rāwhiti e noho ana. My name is Tricia Walsh. I'm from the first place to see the sun, te tai rāwhiti or Gisborne. And I'm here wearing a lived experience pōtaio hat, kia ora. And I'm going to hand it over to Rita.
Thank you, Tricia. My name is Rita Sørli, and I'm a professor in social work at the University in Tromsø, also called the Arctic University of Norway. And Tromsø is, as you might know, about 2,000 kilometers from Oslo, up in the north. So the opposite part of the country from Eivind and Emma. I am also a senior supervisor at the Norwegian Health Directorate, and I work with mental health and substance abuse research. So I'm very happy to be here today. Thank you. And I will hand it over to Sarah.
Kia ora tātou. Hello, everybody. My name is Sarah Helm. I'm the Executive Director of the New Zealand Drug Foundation, proud co-authors of the report, or co-publishers of the report, and it's a pleasure to be here today, kia ora, and handing back over to Emma, I think it is.
Thank you to our wonderful panel for joining us. Now, Philippa will give a short presentation of the report before we dig into some questions.
Thank you, Emma. I hope you can all see my screen okay. So I'm going to run through highlights of the report. This isn't really a perfect summary, and I'll try and give a bit of a flavour of the status quo in New Zealand. I just want to acknowledge my co-authors on this. It certainly wasn't a solo effort. So just highlighting some of the sort of demographics of methamphetamine usage in New Zealand. It's quite a small number of people who use methamphetamine. About 1.2% of the adult population have used it in the last year, but only about 8,000 people use the drug at least monthly. And like Norway, New Zealand has a population of about 5 million, so the numbers are quite comparable. For the people who use methamphetamine regularly, they're likely to be somewhat older, in their mid-30s, male and Māori. So 38% of the people who use regularly are Māori, whereas they make up only 17% of the general population. Methamphetamine usage is much more likely in poorer neighbourhoods and by people living with disabilities. And there's just been a research paper coming out that's looked at the determinants of or factors that make people more likely to use methamphetamine, both when they're younger. There's sort of things like family turmoil, antisocial behavior, and when they're older, it's stressful events like unemployment. In New Zealand, usage is concentrated in rural towns in Northern, Bay of Plenty and Hawke's Bay. This is the north and east, the North Island, and these are places with large Māori populations. We've also looked at the reasons that people use methamphetamine. One group that stood out and which somewhat surprised us was adults with undiagnosed ADHD, that's attention deficit and hyperactivity disorder. There are a few interesting things. Despite what we know about the demographics, our treatment and service provision doesn't line up with it very well. A lot of the treatment provision is actually in larger cities rather than in the smaller places where there are a large number of people using methamphetamine. Despite the large number of Māori people who use methamphetamine, there's very little provision of what we call kaupapa Māori treatment, which is treatment based on a kind of a Māori cultural view or a Māori philosophy. And these programs are generally more effective for Māori people experiencing addiction. Just coming, so that's the demographics. Treatment is obviously really important. We have some really good treatment approaches in New Zealand, but we lack resourcing, so people are often waiting a long time to get them. And about half of people who want treatment miss out. And again, some of those things are inaccessible. We've also looked at how effective treatment is. This is actually from an Australian study, which is comparing people who receive no treatment with those who go through a residential rehab program. We see that even if people don't receive any form of treatment, generally over time, their methamphetamine usage will decrease, and some people will give it up entirely on their own. But if we look at those who receive treatment, the picture, if your goal is abstinence, is not very positive. 3 months after residential rehab, more than half of people have managed to be abstinent, but that drops down to only sort of about 25% after 3 years, which is actually relatively low. But if we take a broader view of what treatment does, and instead of focusing entirely on abstinence, we look at people's well-being, things that they believe are important to them, so their ability to hold down a job, maintain relationships with people, to feel calmer, to have a bit more impulse control, those kinds of outcomes, treatment starts looking much more effective. And if we look at people's ability to use methamphetamine less than weekly, then the treatment is actually really quite successful. And, the large majority of people going through treatment experience positive outcomes. It does also suggest that sort of, it's not just about one round of treatment. Sometimes some follow-up and aftercare is also needed. So I'm not expecting people to see what's on the slide. I would definitely recommend reading the report. But we did map out the harms from methamphetamine. We looked at the whole supply chain from production, wholesaling, retailing, consumption, where people get the money for their consumption, as well as the legal framework, and mapped out the harms and who those harms accrue to. We didn't attempt any quantification. But I'm just going to pull out a few highlights for you. One is that just a few sort of facts about the New Zealand market. We used to have a lot of domestic manufacture with the use of pseudoephedrine, which is an over-the-counter cold remedy, which can be made into methamphetamine. But over-the-counter sales were banned in an attempt to control methamphetamine. It didn't really have any impact on methamphetamine usage, but it does mean that most of our supply comes from international cartels, some from kind of the Golden Triangle in Southeast Asia, and quite a lot from Mexico. This has definitely changed the dynamics of the local market, arguably become more violent, partly as a result of that. And it's also enabled other drugs such as cocaine, which used to be almost unheard of in New Zealand, to become relatively popular. New Zealand has some of the highest prices in the world for methamphetamine, which means we have very large profit margins. There's a lot of very aggressive marketing of the drug. And in some areas, this has led to reduced availability of anything else, particularly cannabis. We also found that regular users often end up selling the drug to pay for their supply. New Zealand has a form of decriminalisation, but anyone caught with a small amount of the drug, it's up to the police discretion whether or not to prosecute them. And police are only supposed to prosecute if it's in the public interest. Unfortunately, that discretion is used in quite discriminatory ways. They're much more likely to prosecute people who are Māori, and they're also much more likely to prosecute if the drug found is methamphetamine versus other drugs such as cannabis. And the fact that people who use often end up also selling the drug means that decriminalisation doesn't necessarily help them, because they may well be being prosecuted for selling. We've also had some quite significant impacts from the stigma and fear of the drug. We had a huge moral panic in New Zealand about methamphetamine contamination. Obviously, methamphetamine production, labs are can be really toxic environments, but the fear was not about those. It was about any indoor environment where people had consumed methamphetamine, where they'd smoked it. And so our social housing provider ended up evicting large numbers of tenants simply for consuming methamphetamine, which made a whole lot of people unhoused because they were already with the sort of last possible housing provider. And it also led to some very expensive and completely unnecessary remediation, and cost millions and millions of dollars for no reason whatsoever. And the last thing, there's a little bit of a thread about ADHD here, which is an unmet health need that leads people into the black market to treat themselves. The drugs used to treat ADHD are themselves stimulants. But because of the kind of panics around methamphetamine, we have very strict prescribing controls on methylphenidate, which is Ritalin, and dexamphetamine, which is a type of amphetamine, much stricter than benzodiazepines, which also have quite high potential for misuse. But probably, we've went through all the health impacts from methamphetamine usage, but the punitive approach has been really bad. We've seen more than 12,000 people convicted of methamphetamine offences in the last 5 years, and almost 4,000 of those people have gone to prison, which has a huge impact on those people, their families, their communities. And none of the measures we've taken have really led to any significant decrease in methamphetamine usage. Our methamphetamine usage rates sort of seem to fluctuate a bit, but they're relatively stable. And yeah, none of our interventions seem to have worked particularly well to date. So we made a number of proposals in the report. Again, I would advise reading it to get a sense of what those are. We really want to make sure that there's actual proven health-based community approaches rolled out. We have a program called Te Aotearoa in Northland, which has been very successful. That is a model of cooperation and collaboration between the local healthcare providers, the hospitals and the GPs, as well as the police and social services, to take a decriminalisation approach to divert people out of the justice system and into healthcare system, providing wraparound social support, and also has had quite a strong sort of multicultural element to that. We would like to see it rolled out nationwide. It has a very high benefit to cost ratio. For every dollar investment program, getting $4 to $7 worth of value back, but it's only been extended to one other region at this point. We've also proposed piloting a substitution therapy style treatment. We have very successful opioid substitution therapy in New Zealand, and there are international models of substitution therapy, Switzerland most famously with their heroin-assisted treatment, and Canada has also been recently exploring models of substitution therapy and safer supply. We also think there are multiple reasons why people use methamphetamine that can be addressed and should be addressed. And one of the more obvious ones is people with untreated ADHD. We also want to see much better harm reduction for people using methamphetamine, and a general sort of destigmatization so they can get help and support more easily. And we really want to see the decriminalization improved, and so that just criminal penalties don't apply for use or possession of methamphetamine, because it's really important to take away the police discretion and opportunity for discrimination. So that's all I have to share. Thank you.
Thank you so much, Philip. I have a question. Coming from a Norwegian perspective, it was really interesting to think about the similarities and differences between the Norwegian and New Zealand context. And one of the things I'm wondering about, and would like to hear your thoughts on, are the transition from a criminal punishment to a health-based focus in this situation. So in Oslo, we are currently trying to roll out a new collaboration with the police and thinking about ways that the public health sector can work more effectively with other sectors of the government. Because what this report shows so clearly is that these topics can never only be solved or handled by the public health sector. So I don't know if you have any examples from the New Zealand context or just thoughts on collaboration with police.
I think collaboration with police is really important. I think here in New Zealand, the police themselves have recognised that they're not going to arrest their way out of this problem. And I think there is a sense, I mean, it's not universal across the entire police force, but there definitely is a sense amongst the leadership that different approaches are needed. And we've seen that in Northland where, they've tried something different and it's worked, but it has been a really strong partnership between police and the health system and social service providers. And we've seen this in other domains as well. So family violence as well. It's been addressed most successfully when there is a partnership between police and the justice system, as well as healthcare and social service providers. So those things are really important to bring together. I mean, there is culture change required on all sides. The approaches taken and the sort of mindsets and ways of working can be quite different between those organizations. But I think if you focus on the outcomes you want to achieve, improving people's lives, health, well-being, that's how you build collaboration and a focus on those outcomes.
Thank you so much. All right, then I have a question for Trisha. So Trisha, I'm wondering if you could tell us a little bit about your experience with methamphetamine use and what the outcomes were for you.
Oh, kia ora. So my journey into the system began generations before me. My mother, Maori, displaced and colonised. My father, Scottish, Irish, poorhouse, colonised, fostered from birth. He went through a faith-based care system, Borstal, prisons. His mechanism for dealing with trauma was alcohol and sex offenses, and he was a rapist. So my abuse, my experience, I was sexually abused from 15 months of age to 12 by my dad, beaten from my mother as a toddler to puberty, and I was othered by my whānau. So, you know, these experiences continued through my adulthood and my relationships. These were the experiences, they weren't just my experiences, they were the experiences of many of my whānau and hapu. But these experiences have impacted on the development of who I was, where I belonged, and who I could become. And it interrupted the growth of my critical learning, my behavior, and my emotion regulation. When I used meth, it was to socialize. In the beginning, it was purely about, you know, spending time with my whānau, and then I got hooked. I lost my sense of self-worth. I forgot what was important, which was my children. I was sent to prison for 6 years, 6 months for possession of a Class A, Class A to supply, which was LSD. And supply was because of the amount, not because I was supplying it. I was also sentenced to 5 years for possession to supply of a Class C drug, cannabis, which was my bread and butter. That's how I was able to buy my methamphetamine. It was by selling cannabis. And I got 6 months for 5 used dollar bags and a pipe. On leaving prison, I did 4 years, 8 months, but I was on parole for 2 years, reporting each week as I was classed as a high-risk recidivist offender. I was told where I could stay, who I could associate with, programs I had to do, psychologists I had to see, constantly reminded that it was a privilege to be in society, and this privilege could be removed from me at any time. I never received any community-based support or prison that helped me to believe that my life could be different. I am, you know, I have sought mahi out of out of my tūranga waiwai because of the stigma that follows me. You know, police had the right to search me whenever, you know, they saw me, and any vehicle and any person I was with under the Misuse of Drugs Act. I had uncountable flags with my name was put through their comm system. My children became their next target, and we were labelled a crime family. So one of my sons was placed in a youth justice facility because I was labelled an unfit mother. I could not keep him as a prisoner in his home between, he was given a curfew between the hours of 7 and 8. And, you know, there's become an embedded, there was an embedded mistrust of police and an intergenerational dislike of the police. You know, these attitudes then became behaviours, and my children were harassed until they reacted in the same way, and they became charged and locked up. So many people who look and sound like me, you know, they've used drugs as ways of dealing with the emotions and stress and colonisation. The outrageous point is that white people also use meth and drugs, and they can afford it without committing crimes. They can also afford rehab lawyers that keep them out of the system. But people who look like me have to keep that Māori go round turning, and that's, you know, that churning of from that pipeline to prison.
Thank you, Trish, for sharing your story. I was wondering, you've touched a little bit upon it, but if you could expand on how stigma and criminalization of drug use undermine the Maori ability to live strong and healthy lives in New Zealand today.
Well, you know, you've got to look at who the Crown have their conversation with, and it's not always mana whenua. It's actually a conversation that has for generations, for 180 years just about, it's existed between the Runanga and the Crown, and it's still a preferred mechanism for decisions to be made and resources to be shared. So the old colonial system still gatekeeps. You know, we are now leading services on behalf of the Crown. When someone returns home from prison to whānau, it's their hapu they return to. You know, we are not so good at welcoming our whānau home in a way that whakamana te tangata. We don't welcome our babies into the world hearing a karanga or a welcome. Our babies are still being removed at birth. You know, everywhere you look, you are reminded of a statistic that represents a certain story, a preferred story or rhetoric that allows Māori to be the boogeyman. And our tamariki, we now see them living up to the expectation. You know, if you hear something enough times, it must be correct, because others have been brainwashing us about who we are and who we are not. And it's difficult to put these experiences of the past, the relationships formed. It's hard to forget these. And, you know, with all of this, you know, the difference between iwi, runanga, mana whenua, whānau, and hapu is it's been a difference that's, you know, it was created 180 years ago. That's how we, you know, how our ways of being and knowing were dismantled. And you know, when it comes to, I guess, engaging with the best engagement for whānau is with people who actually, their community, who knows what they're feeling, who knows what they've been through. And mana whenua will remain. It'll remain beyond the length of a rehab, beyond the length of a prison sentence. And, you know, I think though there's still raru within whānau, and for me, the biggest impact that colonisation has had that stops us from standing together in our as in Māoritanga is patungako, which is a soul wound. And you know, we're still on a journey of discovery to unpack that.
Thank you. It's really powerful to hear your story, and it's an honor to have you here. I have a question for Rita. Thinking about the situation in Norway in relation to methamphetamine use, do the harms fall most heavily on Indigenous populations, like what Tricia is telling us from the New Zealand context?
Well, it's really hard to say in a Norwegian context, because we do not have any registration of ethnicity in Norwegian statistics. So we do not know how many of the Sami indigenous population who actually uses the illegal drugs.
Yeah, this is something I am working on in my PhD too, and I think it's pretty shocking when you look at other contexts and the power that data can have in policy processes. And I think this report has really shown that, right? Knowing the connection between ethnicity, health, and criminal justice, for example. What are your thoughts on this? Is this something that we should change? It's a very complicated issue in Norway, but you know, having studied medicine in Norway, we didn't learn anything about the Sami population over 6 years. How do we right this injustice?
It's kind of a Gordian knot, because, you know, it's really closely connected to our colonization history as well. I can recognize what Trisha is saying in her story, and it's hard to know how to solve this because we have different interests in when we talk about the statistics. Some people really want the ethnicity to be a part of our statistics, others don't. And you know, it's also hard, especially in the area where I live, in the northern part, which is kind of a core area in Norway within the indigenous land of Sápmi, as we call it, because most of us are a mix between, you know, Finnish ancestors, Sami indigenous people, and Norwegians. So many people here in this area, they don't even know their own ethnicity. And, you know, during our grandfather's generation, the language was taken away from us. So most of us, we don't even know the ethnic background of our grandparents. So it's really a complicated area to walk into. And then, you know, the Sami parliament, both in Norway, Sweden, and Finland, they want all research that is being done to be to have a collective, what do you call it? Godkjenning.
Approval.
Approval.
Yeah.
Before you can do any research. And the problem is that most of the parliaments only recognize and approve research which is being done by indigenous researchers. But we live in a very rural area where there already is very few researchers. So it's kind of, the whole thing is very complex. But what we do know is that we need more research related to the indigenous population, both connected to mental health and substance use.
Thank you. Yeah, I think we have a lot to learn from the New Zealand context. Norway has a long history of harmful assimilation policy, of internment schools, of I'm trying to find the right words here, of making illegal and impossible the continuation of Sami language and culture. And to today, I want to acknowledge this here. We are having large Sami protests in Oslo. So this is very much an ongoing conflict and injustice. So definitely something we need more research and activism around. So on a general basis, Rita, what are the interventions that have worked best to increase equitable outcomes in harm reduction and treatment in Norway?
Yeah, I want to continue listening to Trisha. I want to tell you a story because before this panel, I was doing a bit of research. I contacted, you know, different competence centers. I contacted the regional hospital. I talked with pathologists, and I spoke with, you know, quite well-known substance use researchers from the region in Sápmi, and I asked them about these questions related to indigenous population, and none of them could give any answers because of the lack of registration, you know. And as Trisha, I'm also interested in stories. I work with narratives, I work with narrative methods, I work with storytelling, and I always work with collaborative research. So I asked one of my good colleagues who used to be a multi-drug addict, and she's currently working as a peer recovery expert in my hometown, and she's working with lots of rehabilitation projects for people with substance abuse experiences. And she's a Sami woman in her early 50s. And I asked her both about, you know, the part of Northern Norway, which we are connected to, has been for many years a really huge amphetamine area in Norway. And most of the opiates are in the south, but Northern Norway, Harstad, Tromsø, Narvik, Bodø, all these places have been well known for their amphetamine access. So I asked her, for her story about this. And she said that one of the reasons was also connected to, you know, the different status of the drugs. So methamphetamine, which in Norway, when you cannot tell whether you get amphetamine or methamphetamine when you use the drug. And she said the status of the drug, the lowest status is connected to heroin, but methamphetamine has somehow a higher status, and the status is increasing, especially among the young population. And she said, you know, they design these drugs in the nicest ways these days. And she said it's becoming more and more popular in the northern Norway area. And it's really interesting because she said it's the cheapest drug you can get. In Norway, it's 5 times cheaper than amphetamine if you compare it, you know, like the clean amphetamine and the meth. And she said for people that maybe are unemployed, they may be in an insecure state in their life, that this is the cheapest drug, and it makes you feel wonderful, and you can do anything, and you can cope with anything, and you feel like, you know, you can do whatever you want, and you can manage until you realize the opposite is actually what's going on. And I find it really interesting, you know, and she also talked about the cultural differences of the use of drugs in Norway. And I didn't realize that there was such a border between the north and the south. And she said that if you ask, you know, people in Oslo, they will go to Narvik or to Harstad to get the good meth. So there's something about the area as well, which is really interesting. And what we know from the police is that most of the meth that comes into northern Norway comes from, you know, the Baltic states. But these things are changing at the moment. So the drug is finding new routes, new ways. And she also said something that I don't know whether I answer your question now because I just get eager. But she also said something interesting because we've been thinking and talking a lot about the consequences for, you know, communities, municipalities, societies. And she said something about, you know, having experienced being a multi-drug addict, using amphetamine was using the cold drug. She said, you reject all close contact with your family, your children, the people you love and care about. You become self-absorbed and selfish. You can even become violent. You forget hunger and thirst. You lack empathy. You feel nothing and you cannot understand that anyone else around you might feel hunger or thirst. And she said, I find heroin to be a much warmer drug. You get warm and loving while intoxicated. I also asked her, this was the point of your question. I'm sorry about the long round. Sometimes stories work their way through. But I asked her about the harm reduction approaches and what would be a good thing to a health-based approach to meth use. And I'm talking about Northern Norway now. And she said, we need clean user equipment. We need healthcare personnel with competence. We need clean places to take the drugs. We need buses with medical equipment in each municipality. We need naloxone nasal spray in every community. Every user and every next of kin need naloxone because they are depending on somebody being close to you, being there if you overdose. And she said, we also need a drug-based treatment offered for amphetamine users. They cannot be given Subutex or methadone, which are drugs that fill the receptors of people addicted to opiates. It will not work. We need a different medicine. If we use Subutex or methadone, we might become doubly addicted. So we need more research on this. What kind of medicines that can work for people using meth or amphetamine. So I guess we have lots of the same challenges, both among the indigenous people in Sapmi and among the Maori population.
Thank you, Rita. I think we can use this webinar as a wake-up call in Norway to really realize how little we know, how unjust it is to know so little, and to change our action moving forward. I'm going to move to Sarah, and I have a question about the importance of the report in the New Zealand context. So if you could tell us a little bit about how the landscape of drug policy right now and how this report fits into that picture.
Oh, thank you, Emma, and thank you, Rita and Trish and others that have gone before. And just want to, I was going to use a Māori word there, support what you're saying about the impacts on Indigenous people, and I'll come back to that. So in New Zealand, or Aotearoa, we like to call it, methamphetamine has been a drug that, or the illicit drug that has caused probably more harm in New Zealand than other drugs, notwithstanding that alcohol sits a little bit above that as a illicit substance. And for a long time, we've been doing the same thing and wondering why we're not getting different results, which I believe is something to do with the definition of insanity. So we really proudly co-commissioned this report with the Helen Clark Foundation because we wanted to dig into the actual evidence, move past the stigma, move past some of the discrimination and fear that has existed alongside that substance because of its prevalence here, notwithstanding Philippa's good point that it's 1% of the population and even less that use it very frequently. But we wanted to look at the evidence. And I think a couple of so some of the findings weren't surprising to us, if you like, and it's just helped to hold that up. For example, there's a really fantastic program that Philippa signalled that's using a Portugal-style decriminalisation approach and focusing more on health-based solutions. We most certainly lack Māori-led treatment and interventions, given what we've all just said in terms of impact on Indigenous or Māori people. The removal of criminal penalties and that sort of thing, of course. But the other two findings that really broke new territory for us, that is useful for us, probably because of that prevalence, but I think useful probably for everyone, is the stimulant substitution therapy stuff that Philippa helped to uncover, but is actually work that's been going on elsewhere. And I just want to highlight that there is great emerging work happening in that space. And I'll point to researchers like Bernard Lefol and Heather Pallas in Canada, who I'm meeting with in coming weeks, who have new research coming out around the efficacy of stimulant substitution therapy, which is something like prescribing somebody either methamphetamine or a different drug that's similar to it. And I see Heather just this week has tweeted some of her results from the patient perspective, saying that for them, stimulant substitution therapy had cut their use in half, had improvements like increased stability and reducing their cravings. And there's some other stuff that then tips into the other main thing that I think that it's helped to highlight for us is that there are some health issues that maybe we could do better, health and social needs that we could do better to address to prevent some harm. And so some of the anecdotes from people who've been involved in prior stimulant substitution therapy work and a little bit of informal stuff in clinics that I've heard from, particularly in Canada, tell us that it seems to work really well for people with ADHD. And so there is some emerging evidence around that work and what we should be doing, for example, diagnosing and treating people. And I think somebody asked a question before, what is this connection? Well, for people with ADHD, they report to us that a stimulant like methamphetamine might often actually make them calmer. So it's addressing some of the pharmacological things that they might otherwise get from a prescribed drug. And so people with ADHD might be self-medicating with everything from caffeine to cocaine, if you like, in order to fulfill that need to help settle their brain. So quite a different effect than it might have on people without ADHD. And some statistics suggest that as many as 25% of people with substance use disorder have ADHD. So it's actually a really important piece of the puzzle there for us to continue to have a look at. There's a lot of stigma and discrimination and misconceptions around that particular issue. So we still have to do some work, of course, to look into it. Thanks.
Thank you. I also have one more question for you. Ivan started this seminar talking about social and political determinants of health, which is a little bit of a jargony type of word, but I'm wondering if you could speak to that, why it previously has been difficult to think social context, to think political context when looking at substance use disorders, and if you have any thoughts on promising arenas for bringing these things together, because there's so much evidence showing that these are interconnected phenomena.
Yeah, it's great to part the stigma, which this report has done, and just really focused on the evidence, And I think our criminalised approach really likes to blame the victim a wee bit. And coming back to Indigenous people here, I mean, it's we've been hearing and connecting with Indigenous people this year from around the world, and hearing the same and similar stories. And it's absolutely no coincidence that Indigenous people have experienced higher drug harm and higher rates of conviction through, colonisation, which also includes subsequent harms like dispossession of lands, culture, language, government, services that are designed for people that aren't us, and intergenerational trauma. And I think as well, I mean, I'll just skip on to a couple of the other groups, people with disabilities, for example, people who are in poorer neighbourhoods. And something I think is really important to note with that is that some of the use from these groups is actually very, very practical. So last week, for example, I was hearing from people in the Philippines saying that they're using methamphetamine to help them work long hours and work multiple jobs. This will be true for some people around the world. Sex workers use it because it helps them do their work. It helps with things like libido. Men who have sex with men use it with chemsex practice. It helps to suppress hunger. It potentially helps people with untreated ADHD. So it's not to advocate for its use, but it's to really understand the drivers and complex causes of meth use and meth harm. And I think as well, we hear, and I think Rita, you touched on this, constantly from people, because we actually run some of the work with people who use methamphetamine. We hear from them that it makes them feel beautiful, confident, secure in themselves, and which is, for groups of people who have been told they're not valued, they're not beautiful, they're not counted in society, what a gift it offers, right? I mean, as Rita has suggested, there are some counters to that gift, but that is a thing, I think. So I just would add just one positive story from New Zealand, which touches on Rita's point before. We have an Indigenous group here in Rangiwaho Marae, led by Manu Caddy and some others just south of Gisborne, who are trialling a native psilocybin mushroom in order to try and treat methamphetamine addiction. They also believe that it might be able to treat intergenerational colonisation trauma. So just a positive story from a dispossessed group of people. Kia ora. Thank you.
Thank you, Sarah, and thank you for your great work. A question for Helen. So we're going to move to thinking about the international context. So if you could share your thoughts on the report from a health and development perspective, especially given your long engagement in the UN.
Well, first thing is, blown away by the stories and the honesty of Trish in talking about what happened to her and the whole context of colonisation and the range of what we call in the health trade social determinants of what led to Trish being in the situation that she was in. And I think also this webinar has brought up issues of food for thought for Norway itself and the implications of understanding this kind of background. I think the core issue is prohibition. You know, there's been so much stigma around those drugs which are classified as illegal that I think it's been easier just for society to turn the other way for far too long. And that's why as a core mission at the Global Commission, we campaign against prohibition. We advocate for the kinds of solutions that Portugal came up with over 20 years ago, decriminalise use and possession and offer people services and a way forward. Obviously, there's long been opioid substitution treatment in New Zealand, always called methadone maintenance, but meth hasn't, until this pilot launched in Northland and now extended to another small part of the country, until they came along, there wasn't a serious harm reduction initiative around methamphetamine, and we need a lot more of it. What I'm encouraged by is the growth in numbers of safe consumption spaces and harm reduction services around the world, but we're really only scratching the surfaces in most countries. And if we really do want to believe in the Sustainable Development Goal principle of leave no one behind, we can't leave behind people who use drugs. They're our sisters, brothers, parents, children, aunts, uncles. We have to see people who use drugs as part of our society, and we have to do whatever we can through our social policy to see that people can remain safe. So that's the mission that I bring to it. I don't want to talk too long because people have put wonderful questions up, and I think they should get an airing.
Yeah, thank you, Helen. I agree. I will start taking some questions from the chat, and I'm sure some of them will be for you. So we'll hear more from you soon. I want to start with a question from Laura Hall. So Laura has written that she developed and facilitated a Kaupapa Maori, I'm so sorry if I'm mispronouncing anything, happen, parenting program in Canterbury. Within the women's prison environment, it seems that many wahine, which I believe means women, are in there due to the connection to meth. Often I hear they are co-offenders and many have no previous convictions. Is that something you've seen in your research? So I'm wondering if this question might be appropriate for Sarah or Philippa, whoever wants to hop in.
Yeah, it's definitely when we're seeing the imprisonment rates and the prosecutions. If you're caught with methamphetamine, I think you're about 6 times more likely to be prosecuted than if you're caught with some other kind of drug. So it makes sense that a lot of those women would be there just for methamphetamine and not really having done anything else. So it does come through in the research. I don't know if someone else has a more sort of nuanced or qualitative response.
Just on a qualitative response, what I basically witnessed when I visited the Aotearoa Women's Prison near Wellington in recent years with the former chair of our Global Commission, and we spoke with women who were in prison for drug offences, and their story was like Trisha's, that nowhere in the community had they ever been offered a service. And it wasn't till they'd been in jail, often for quite some time, that there was any kind of service offered to them. And I have to say, unfortunately, and I guess because they're in a prison environment, all the services were abstinence-based. Now, my impression is that you just have to offer a wider range of services. I was last week at the North Richmond Medically Supervised Injecting Centre in Melbourne, and I saw there a service in the heart of a community which has quite a lot of drug use, people coming in, no questions asked, using under supervision, going to a recovery room, over time enough trust being built for a number of them to start asking about other options. But first get people in the door, don't insist on abstinence, I think is a very important part of a comprehensive menu of harm reduction approaches.
And actually, sorry, one more thing, moving beyond sort of the pure just possession prosecutions, A lot of people who work in the supply chain, either selling methamphetamine or in distribution or whatever, they're not necessarily making a kind of free choice to engage in that kind of activity. You know, they'll have been shut out of the regular labour market for various reasons. But there are also people who are very directly coerced into doing that work because they've accumulated debts to their drug dealer or something like that. And there's often a lot of coercion and lack of free will in people participating in that activity. And then to kind of hold them accountable by sending them to prison is manifestly unjust when they've been forced to do that.
Thank you. I can say from the Norwegian context, we have a lot of data saying that the transition out of prison is also very precarious. So the connection of services from in prison to transitioning back to communities is something that also really needs to be strengthened in the sort of pathway of providing care. All right, we're going to move on to a question from Heidi Baker. Oh, Rita has a comment.
I just want to make a comment on this, you know, what Helen is bringing into the dialogue about, you know, having more holistic services. What we see in SAPMI is that peer recovery, user-led rehabilitation often is very successful. But when you do peer recovery-led rehabilitation, you need good support from both the municipality and very often the health directorate. So there has to be a cooperation between, you know, both the political level, the system level, the service level, and the user organizations. So that was just a comment from the Norwegian side.
Thank you. Yeah, this next question I think will relate to that, and we'll hear more from you, Rita, but it's a question about what a Maori approach to harm reduction and treatment intervention might look like. So I think participants here are wondering about conceptualizing what does that mean? And I think Rita also, from a Norwegian perspective, what would a user-led or Sami-led initiative for harm reduction look like? So maybe we can start with Sarah and then move to the Norwegian context from Rita.
Yeah, Trish, feel free to jump in on this one as well. We've been doing a little bit of thinking and talking about Māori-led harm reduction, actually. So harm reduction has been somewhat defined by a non-Indigenous way of thinking, but actually our culture actually has a lot of harm-reducing things in it already. And so we have some cultural frameworks and practices that are in and of themselves harm reducing. We also have some harm reduction activity already in place. The thing that I would point to is that there are a number of Indigenous-led harm reduction organisations around the world already. I just visited a couple in Canada, for example. We have some emerging things happening here in New Zealand, and actually, you know, there are components of it in a range of places where you have traditional practice and traditional healing happening alongside some Western practices as well, and merging those two things together in a way that also enables people to connect to culture and self. So we need to decolonize our laws and our systems and our support mechanisms, and we need to indigenize the provision of service so that it's by and for Māori in a way that's really good for us and good for Indigenous people. I hope I answered that question properly. Sorry.
Thank you. Trish, would you like to add anything to that?
I guess for me, it's around providing you know, for Māori by Māori, and I'd say that it's about you know, Moana Jackson, he said we once were gardeners, and you know, when you're a gardener, what you're doing is it's not about what you're going to grow, but it's about creating the optimum environment for whatever to grow. So this is about, for me, it's about creating an environment where, one, we feel safe enough to to look at the soul wound of colonization, where all of those outcomes that we talked about are present, to unpack those. You know, but what we do when we talk about, I'm going to say the word intergenerational trauma, I don't like that, it's patungrako, is we forget that there's also intergenerational wisdom, you know, and it has been hidden by us through the colonial process, but that's the intergenerational wisdom and intergenerational healing. And those, once you start talking about these things and changing the story, flipping it on its side, you know, what it does is it allows us to, you know, to be brave and to acknowledge that the magic exists inside us. It's not something that someone can do to us. It's something that we have to do to ourselves. And that's the magic.
Thank you. That's it's a wonderful way to think about it. I think we can use that here in Norway too, thinking about initiatives. So Rita, if you could tell us a little bit about, are there current initiatives that maybe would be comparable or opportunities?
Yes, I think at the moment we're doing a research project connected to user-led rehabilitation, and we've been doing interviews with all the user organizations in Norway. And we have been asking the user organization, what kind of competence do you need to, you know, lead a service that is led by you as users? And they, you know, one of the most important part that everybody agrees upon is that we have to understand rehabilitation. That is not something that starts after prison or when you get out of a treatment. It should be, you know, included in the whole process. So we have to take a look at people's life in a more holistic way. And we have to start with the first meeting, and we have to ask people, what do you need? What do you want? What can make your everyday life better? And how can we help you? And, you know, there has been several user-led services in Northern Norway. Some of them are in Sápmi, some of them are in the, you know, the towns I mentioned, where the amphetamine use is quite high. And this has been really successful, but you know, the problematic area is getting the funding, getting the municipality to understand the value of these services, getting, you know, the Norwegian Health Directorate to understand the values in the work that these services do. And we had a wonderful project in Tromsø, which was a user-led housing service for people, where you were welcomed in, and there were only peer experts working there, and you could stay there for 3 years. And they were managing this service for 12 years, and none of the people who had lived there are today using drugs. They are back in work, back in activity, doing their studies, working, taking a part in, you know, society. So I think I just loved, you know, what Helen said. We have to remember these people should and must be included in our everyday community, in our life, and they have to take a part. It can be your colleague, it can be your parent, can be your daughter, you know, and just accepting it and looking at the resources, the experience. And we have been talking lots about in different research projects that I'm working in, that you get a really good competence if you have the experience of having lived on the street for several years. You get a good competence on how to survive and manage, and how can we use this in a positive way. So this is something, Emma, when you ask me about these questions, it's like turning on a button, because, and I also think we as researchers need to do more collaborative research, walking along with, instead of researching on people. We have to do collaborative research together so that both we as the community, as researchers, as participants in our community and municipalities understand this and learn together how we can make things work.
Thank you, Rita. Sounds like a research collaboration waiting to happen, hopefully soon. All right, I'm going to take a question here and pose it to Helen. So the question is about safe injecting rooms in Sydney, which Lee Armstrong writes have had some fabulous outcomes for people using drugs. So Lee is asking how far we are away in Aotearoa for such a facility, and then we can answer shortly as well if Norway has such facilities.
Sarah might like to add a little on an initiative that she and the Auckland City Mission were part of, because the Sydney example is of an initiative that was set up by the Uniting Church and the Auckland City Mission, with its experience in working with people who are homeless and on the streets and who have a range of addictions. Could make them sort of perfect kind of partner to support something like this. But I haven't visited the Sydney Harm Reduction Service. I did visit this one in North Richmond and Melbourne, and I was really blown away, particularly listening to the experiences of people who used the service, who told us what it had meant to them. Prior to that service being in place, I'm told it was not a rare event for the community to see a dead body in the street. You don't see that now, because people can come in and safely consume and be offered, if they want other options, those options are there. I also heard people talk about their hepatitis C, which they had for 20 years, being cured with treatment that had been made available because this facility actually existed. Look, I'm just such a big fan of harm reduction, of not judging people, of working with people as they are, where they are, and supporting them to be able to live their life. And I think we could learn a lot in New Zealand, not only from Melbourne and Sydney, but from what's happening in Vancouver, from what's long happened in Switzerland and a range of other places. We need drug consumption rooms here where people can safely consume and have then the space and to think about where they want to go with their lives.
Thank you, Helen. I see we only have a few minutes left, so I think that's going to have to be the end of this discussion. It's been wonderfully enriching, and I think we have a lot to think about and work on in Norway and New Zealand, hopefully together. I will hand over to Kali, who will say a few final words. Thank you, everyone, for participating.
Thank you, Emma. We are running out of time, so I'll be very brief, but I just wanted to round us off. Thank you so much for watching. I really enjoyed the talk, and I learned a lot, and I really hope you did too. Our panelists, as I expected, you were just full of amazing information. Thank you all so much. You were a delight to listen to. Also, thank you to you, Emma, a great facilitation, and to Ivan, thank you for suggesting and helping to organise this webinar. A great idea, and I think we've all got a lot out of it. Last but not least, thank you to our audience for your engagement and for your valuable questions. I see there were people joining us from all over the world, which is fantastic. So hopefully the experiences from Norway and New Zealand will be able to, seed fruit around the world as well. And just also on that note, a reminder that today's webinar has been recorded and will go onto our website. So please share that with your networks. Cheekily, while you're here, I would just like to invite you to consider becoming a member of the Helen Clark Foundation and signing up to our newsletter. We're a charity, so we really appreciate your support. So let's now end the meeting as we started. I'd like to share a karakia with you, which I'm just going to put the text into the chat. a karakia which acknowledges that our conversation and our time together is finished for now, and it asks that the strength and life force of our ancestors be with each and every one of us. So kia tau ngā manaakitanga a te mea ngaro, ki ronga, ki tēnā o tātou, kia mahia te hua mākihikihi, kia toi te kupu, toi te mana, toi te aroha, toi te reo Māori, kia tuturu, ka whakamaua, kia tina. Tina, hui e, tai ki e. Thank you everyone for joining, and I hope you enjoy the rest of your evening or morning. See you later.
Thanks all. Special thanks to everyone who spoke and for the Norwegian colleagues for the collaboration. It's been fantastic.
Thank you so much.